Good morning, everyone. The diagnostic framework of benign paroxysmal positional vertigo proposed by the Barany Society in 2015 has provided the much needed standardization in our field. However, like all consensus based criteria, it reflects the prevailing understanding at a given point in time and is not immune to revision as the new clinical observations emerge. In this presentation, I will argue with clinical cases that the current criteria for posterior semicircular canal cupulolithiasis are incomplete. Specifically, they emphasize the half Dix-Hallpike test as the defining positional test for eliciting persistent nystagmus while under recognizing the potential of the conventional Dix-Hallpike test to evoke similar persistent responses. I propose that this limitation arises from an implicit assumption of a uniform posterior cupula orientation by the Barany Society. In reality, the morphology of the posterior cupula is variable depending on whether the cupula is neutral, canal-angulated, or vestibulum-angulated. The same Dix-Hallpike test can produce no nystagmus, downbeat torsional positional nystagmus, or even persistent upbeating torsional nystagmus. This has important diagnostic implications. It means that the persistent positional nystagmus is not exclusive to the half Dix-Hallpike test, and relying solely on this maneuver may lead to under recognition or misclassification of the posterior semicircular cupulolithiasis. Equally important is the issue of differentiation from the short-term posterior semicircular canalolithiasis. Both conditions can present with persistent positional nystagmus, which directly challenges the traditional reliance on duration as a distinguishing feature. In this context, I will emphasize that the inversion test is not only optional but essential. A reversal of nystagmus during the inversion confirms cupulolithiasis, whereas its absence supports short-term canalolithiasis. Therefore, the central message of this talk is twofold. First, the Dix-Hallpike test itself can evoke persistent nystagmus in posterior semicircular cupulolithiasis depending on the cupular morphology. Secondly, the inversion test is indispensable for accurate differentiation between cupulolithiasis and short-term posterior semicircular canalolithiasis. Through this lens, I invite you all to reconsider whether our current diagnostic criteria are sufficiently inclusive or whether they require refinement to better reflect the spectrum of the real world clinical behavior. So, the title slide here, posterior cupula morphology and the positional tests in posterior cupulolithiasis. The four diagrams that I have shown in this patient who is in the right Dix-Hallpike test are the labyrinth of the right side, and here extreme left is the neutral cupula. To its right is a canal-angulated cupula, and just to its right is the vestibulum-angulated cupula, and to the extreme right is the extreme vestibular-angulated cupula. This diagram is from a article published in 2025, Physical Therapy of Posterior Semicircular Cupulolithiasis, in which I was one of the co-authors, originally adapted from the Darius Kokos paper of 2022. So these are the criteria of the Barany Society which were laid down in year 2025 and published in its official Journal of Vestibular Research. What do these criteria say about the cupulolithiasis of the posterior semicircular canal? I feel that the Barany Society criteria for posterior semicircular cupulolithiasis, they are clinically useful but not universally encompassing. Cupulolithiasis of the posterior semicircular canal, criteria A, B, and C. A. Recurrent attacks of positional vertigo or positional dizziness provoked by lying down or turning over in the supine position. B. positional nystagmus elicited after a brief or no latency by a half Dix-Hallpike maneuver, beating torsionally with the upper pole of the eye to the lower ear and vertically upward to the forehead and lasting more than a minute. C. Not attributable to any other disorder. So, the so much of the controversy which I have raised about these criteria is the use of the half Dix-Hallpike maneuver only. Why not the Dix-Hallpike test? That I will show with three clinical cases. Secondly, the criteria of eliciting a persistent nystagmus lasting 1 minute in half Dix-Hallpike position is not exclusive to the posterior semicircular cupulolithiasis. In the recent years, the publication of Darius Coco of 2022 published in Journal of Otology has found that a persistent upbeating ipsitorsional nystagmus during the half Dix-Hallpike test was also observed in cases of short-arm posterior semicircular canalolithiasis. So, how to differentiate these two? And these two are can be differentiated by the inversion test, which are not included in the Bárány Society criteria, and this is indeed a red flag which I have marked it. This is a landmark paper by none other than the legendary John M. Apley from Portland, Oregon, published as early as the outset of this century in 2001. And what did he say? Each cupula has two potential provocative positions oriented 180 degrees to each other. Earthward deflection in one position is excitatory and in the other position inhibitory. If the particles are adherent to the cupula, persistent nystagmus will occur in both positions in the same plane but will reverse direction when the head is turned through 180 degrees. Further, he says that the identification of this nystagmus reversal with head inversion confirms the presence of cupulolithiasis. If persistent nystagmus maximizes in one provocative position but does not occur in the inverse position, it suggests that the cupulolithiasis may be present due to non-adherent particles falling away from the cupula in one of these positions. But in that case, the diagnosis is less certain. When Apley wrote this paper in 2001, there was only one publication from OS that vaguely described the short arm posterior semicircular canalolithiasis. Two main points the OS raised in the same year was that the short arm posterior semicircular canalolithiasis cases do not have a reversal nystagmus as they are uprighted from the Dix-Hallpike position, and they lack a orthotropic nystagmus while carrying out an Apley maneuver. But no further details of the short-arm posterior semicircular canalolithiasis were described by O's in its first noting published in 2001. Later in the year 2011, Bela Buki from Austria and his colleagues found in a certain subset of their patients that patients without oculomotor responses during the Dix-Hallpike test, they have a setting up vertigo and a concomitant truncal retropulsion, which they documented in their patients with ad hoc posturography. But they could not find any oculomotor responses during the Dix-Hallpike test, and that's why they referred these cases as subjective BPPV or type 2 BPPV. It was only in the year 2022 that the SCOCO published the article setting up vertigo as an expression of the posterior semicircular canal heavy cupula and posterior semicircular canal short arm canalolithiasis, and this was published in the Journal of Otology, and he described the inversion test in such cases to differentiate between the posterior cupulolithiasis and the short arm posterior semicircular canalolithiasis, which was described much early by the John Apley in his article around 21 years ago. So nothing new, but the SCOCO has emphasized the importance of inversion test, which for some reason has been excluded by the Barany Society in the criteria of posterior semicircular cupulolithiasis. Why the inversion test is positive in posterior cupulolithiasis? The position A is long sitting, position B is the half Dix-Hallpike testing, and when the patient is in half Dix-Hallpike test, the ampulla deflects ampulofugally, resulting in the ipsitorsional upbeating positional nystagmus lasting more than a minute. And when the patient is transitioned to left lateral recumbent with nose down, there is a inhibitory ampulopetal deflection of the right posterior cupula, resulting in the left torsional downbeating nystagmus. And this is a hallmark or a telltale sign of the posterior semicircular cupulolithiasis, which should be present in almost every case. And this holds true even for the Dix-Hallpike test. A nystagmus which is right torsional upbeating and persistent in the right Dix-Hallpike test should become left torsional and downbeating in the inversion position, that is left lateral recumbent with nose down, and that we are going to show here. This is the article published by Darius Coco in year 2022 about the sitting of vertigo as an expression of posterior semicircular canal heavy cupula and posterior semicircular canal short term canalolithiasis. So, what is the influence of posterior cupula shape on the positional nystagmus, that is the posterior semicircular cupulolithiasis? This is a cupula which is a neutral cupula, as you see here in the figure A and figure B. And during the right Dix-Hallpike test, this is a right-sided membranous labyrinth and right-sided posterior cupula. The long axis of the cupula is parallel to the Earth's gravitational vector. Therefore, the right Dix-Hallpike test does not evoke any nystagmus in such conditions, and for this reason, we have to use the half Dix-Hallpike position to make it orthogonal to the gravity so that it can deflect by its weight. So, this is a person with the neutral right posterior cupula. A 72-year-old female came with a history of positional vertigo lasting few minutes on getting up from supine and in right lateral recumbency. Right half Dix-Hallpike test, inversion test shows a persistent nystagmus. This is the Dix-Hallpike test. We waited for full 1 minute and it did not evoke any positional nystagmus. So as far as this patient is concerned, we do agree with the Bárány Society criteria that we would have missed the diagnosis of posterior semicircular cupulolithiasis if we had not carried out a half Dix-Hallpike test at the end of 1 minute by anti-flexing the cervical spine to 60 degrees, making the head move 30 degrees above the horizon to make it a augmented half Dix-Hallpike test. So, to label a nystagmus as persistent during the positional test, that is the Dix-Hallpike test that we are going right now, it has to be maintained for a minute. But there was no nystagmus. So, what did we do after the end of 1 minute? Anti-flexed the cervical spine 60 degrees, as you can see right now on your screen, and transforming this into a half Dix-Hallpike test. As soon as the half Dix-Hallpike position is attained, there occurs without a latency a right torsional upbeating positional nystagmus, and we need to observe it for full 1 minute before carrying out an inversion test. An inversion test in this patient would mean transitioning her to left lateral recumbent with nose down. If the nystagmus that you right now see on your screen, which is right torsional upbeating and possibly persistent, last for a minute, and then in the inverse position, that is left lateral recumbent with nose down, reverses the polarity of the torsional and vertical components, it is likely to be because of the cupulolithiasis of the right posterior semicircular canal. And indeed, the nystagmus changes direction. It becomes downbeating with the upper corneal poles of both eyes torsionally beating to the patient's left, as you can see now, as she has stopped blinking now. So this is a posterior cupulolithiasis of the right posterior semicircular canal with a posterior cupula which is neutral in the shape, that would not evoke an nystagmus during the Dix-Hallpike test. And as per the Barany criteria, we need to carry out a half Dix-Hallpike test that we actually did, and we diagnosed this in conjunction with the inversion test. What happens if the posterior cupula is canal angulated? This is a canal angulated. The angle is towards the canal of the posterior semicircular canal. Here it is the canal angulated. In the right Dix-Hallpike testing, this would deflect ampulopetally, and that would result in the left torsional downbeat nystagmus. And this is shown here in this video. Again, a 70-year-old female who came with a history of positional vertigo for past 2 weeks. Right Dix-Hallpike test shows you left torsional downbeating positional nystagmus for a minute. We waited in the right Dix-Hallpike position. Immediately, a nystagmus occurs, and as you can see that during the standard right Dix-Hallpike testing, the nystagmus begins with almost no latency, is left torsional and downbeating. It is an inhibitory nystagmus resulting from a canal-angulated right posterior cupula. After 1 minute, what did we do in this patient? We antiflexed the cervical spine around 60 degrees so that the head was oriented 30 degrees above the horizon, and thus making a right Dix-Hallpike position to look on the effect of on the ongoing nystagmus. In the right Dix-Hallpike position with augmentation, the nystagmus disappears. So the Bárány Society says that you need to do the half Dix-Hallpike test. Here the half Dix-Hallpike test, there is no nystagmus, and if we would have carried out the half Dix-Hallpike test directly, we would not have evoked this nystagmus, and we would have missed the right posterior semicircular cupulolithiasis in a patient with canal-angulated right posterior cupula. So indeed the inversion test was done by transitioning her to left lateral recumbent with nose down, and nystagmus now reverses polarity and becomes left torsional and upbeating, and thus confirming the posterior semicircular cupulolithiasis because of adherent otoconal debris on the posterior cupula. The posterior cupula, which is canal angulated. And here the Bárány Society criteria totally fail as far as the half Dix-Hallpike testing is being only advocated by them to diagnose posterior semicircular cupulolithiasis. This is another situation where the posterior cupula, as you see in the diagram A and B, is vestibulum-angulated. The angle is towards the vestibulum, and in the right Dix-Hallpike testing, it is likely to evoke a right torsional upbeating positional nystagmus, which should be more than 1 minute in duration, and there is a excitatory ampulofocal deflection, as you can see here, because the gravitational vector will act here on this. So this is a gentleman, 40-year-old, came with the history of positional vertigo for past 3 days. Right Dix-Hallpike test, persistent right torsional upbeating positional nystagmus, which changes and becomes inversion test positive. Right Dix-Hallpike test without any latency evokes a right torsional upbeating positional nystagmus. Again, see it clearly. It is not the right Dix-Hallpike, half Dix-Hallpike position. It is the standard right Dix-Hallpike test. And we'll observe for the elicited positional nystagmus for more than a minute, and then we'll carry out the inversion test by transitioning the patient to left lateral recumbent with nose down. The nystagmus continues unabated. We waited for another one more minute, and now the patient is being transitioned to left lateral recumbent with nose down. The nystagmus changes direction with the upper corner poles of both eyes torsionally beating to the patient's left, and the vertical component changes from up beating to down beating. So this is a positive inversion test in a patient with vestibulum-angulated heavy right posterior cupula due to adherent cupulolithiasis. We again transitioned him to the right Dix-Hallpike position to confirm that the nystagmus again reappears. This is a excitatory nystagmus due to right posterior heavy cupula, which is vestibulum-angulated, and indeed we see reappearance of the excitatory right torsional upbeating positional nystagmus, which is persistent. So let us see what happens when we anti-flex the head 60 degrees to carry it above 30 degree above the horizon. The nystagmus disappears here. So again in this patient with the vestibulum-angulated right posterior cupula, if we would have relied only on the Bárány Society criteria and carried out only the half Dix-Hallpike test straight away, it would have been negative and we would have missed the diagnosis of right-sided posterior semicircular cupulolithiasis in this patient. So now from these three examples, I can say with the evidence, again right Dix-Hallpike positioning is done, and there is again reappearance of the right torsional upbeating positional nystagmus. Intermittent square wave jerks are also present. Don't confuse with the nystagmus which is ongoing and the intermittent square wave jerks which are occurring. The nystagmus is persistent right torsional upbeating. Again, the cervical spine was antiflex 30 degrees to bring the head 30 degrees above the horizon. The nystagmus disappears. I repeat here again, in this 40-year-old patient with 3 days history of positionally triggered vertigo, the right Dix-Hallpike test, not the half Dix-Hallpike test, evoke a persistent right torsional positional nystagmus lasting more than a minute that changed to left torsional and downbeating in the inversion test, that is left lateral recumbent with nose down. And we would have missed the diagnosis if we had carried out the half Dix-Hallpike test straightway, as has been recommended by the Bárány Society. We do agree that the optimal positional test for evaluating positional nystagmus of posterior semicircular cupulolithiasis and short-arm posterior semicircular canalolithiasis is half Dix-Hallpike test, but that should be done in conjunction with the inversion test. But we do add here that the Dix-Hallpike test is not useful in patients with only a neutral heavy right posterior or left posterior cupula. The In that case, a neutral cupula of the right posterior canal that needs to be evaluated by the half Dix-Hallpike test in conjunction with an inversion test. To differentiate the two, we need to do the inversion test. The inversion test is negative in short arm posterior semicircular canalolithiasis, and it is positive in the half Dix-Hallpike position to inversion positioning in patients with posterior cupulolithiasis. However, the patients having heavy posterior cupula due to cupulolithiasis in a having the canal-angulated or vestibulum-angulated cupula, the half Dix-Hallpike test is likely to miss the nystagmus, as we have demonstrated in two of our cases in the previous videos. Right posterior cupula shape and the evoked positional nystagmus. So there are three columns here: right posterior cupula shape, right Dix-Hallpike test, and inversion nystagmus. Vestibulum-angulated cupula of the right side would evoke a right torsional upbeating positional nystagmus lasting more than a minute during the right Dix-Hallpike test, and during the inversion positioning, that is the inversion test, it would become left torsional and downbeating. A canal-angulated right posterior cupula during the right Dix-Hallpike test would elicit persistent left torsional downbeat positional nystagmus that would change to right torsional upbeating in the inversion test. A neutral posterior cupula would not evoke any positional nystagmus in the right Dix-Hallpike test. We need to carry out the half Dix-Hallpike test by anti-flexing the cervical spine to 60 degrees to bring the head 30 degrees above the horizon to evoke the persistent upbeating right torsional positional nystagmus of the right posterior heavy cupula in a patient with neutral posterior cupula shape. And in that case, the inversion test would be non-informative when no positional nystagmus is evoked. However, if the positional nystagmus is evoked during the half Dix-Hallpike that has been done by augmentation, then it would be positive. A extreme vestibulum-angulated right posterior cupula would result in persistent right torsional upbeat positional nystagmus, but on inversion positioning, the nystagmus would not change direction. That is, the inversion nystagmus is absent, and this is the experience which has been shared personally with me and in my also series of my patients, that extreme persistent right torsional positional nystagmus is elicited during the right Dix-Hallpike test, and when the patient is transitioned to left lateral recumbent with nose down, the nystagmus disappears, and when we again carry out the patient, transition the patient to the right Dix-Hallpike test, it reappears. So this would not occur in patients with short-term posterior semicircular canalolithiasis. It is suggestive of extreme vestibulum-angulated right posterior cupula in this case that would not show up any inversion nystagmus. So these are my objections or skepticism about the criteria of posterior semicircular cupulolithiasis laid down by the esteemed Bárány Society in year 2015, but now it is almost 11 years. They need to be changed in the view of ongoing research, and the ongoing research is not always done by these researchers who publish too much. Thank you very much. I finish my talk here.